Hello, good evening, and welcome to today's Facebook Live. My name is Alec. I'm the MD of Wound Care People. I'd like to welcome you all and thank you all for joining us this evening. This session tonight is Barriers to Healing, and it's sponsored by ConvaTec. So first and foremost, I'd like to thank our colleagues at ConvaTec for supporting this session. And tonight we're joined by two wonderful speakers. We've got a first-time Facebook Live presenter and somebody that's been with us before. So we have both Julie Mullings, who is the lead nurse for tissue viability and infection prevention and control of community services at Manchester University NHS Foundation Trust, which is a bit of a mouthful. So Julie, did I get that right?
You certainly did, Alec. Yeah.
Okay, brilliant. And Joanne Wilkins, who's the clinical strategy manager in advanced wound care for ConvaTec. And this is your first time with us presenting, Joanne?
It is, yes, Alec.
But I know how excited you are, and that's the main thing.
Yeah, definitely.
So just a little bit of housekeeping from me before we start, and it's the usual things. Certificates will be available at the end of the presentation via a link on the screen. Ask as many questions as you like. We'll be coming back for a live Q&A after the presentation. So do please engage with your colleagues through the chat section of the Facebook page there. Like I said, send us as many questions as you possibly can. Bear with us if we get any technical issues. They don't happen very often, but as you can see, we're still being ultra cautious because of COVID, and we're presenting from our homes this evening. I think that's it from me. Ladies, I'm going to hand over to you, and I'll be back to join you for the live Q&A in a while. Good luck, and I certainly look forward to reading the comments from the viewers and following along with the session this evening.
Lovely, thank you, Alec. I'd just like to extend Alec's warm welcome to everybody and thank you all for choosing to spend your time with us this evening. So wound healing, well, it's quite a complex process and it's made up of different processes at different stages, and it's complicated even when it's going well. And then we have the times where it's not going so well, and then it gets really complicated. And we have to stop, we have to think, we have to figure out what's going on and why is this happening. And we need to try and discover and identify what barriers are being presented to us and why these barriers are preventing that wound from healing. And the presentation this evening is going to centre around the identification and management of three of the local key barriers to wound healing that we do see. Because if we can identify that problem, we can then put appropriate plans in place to be able to manage those problems. We can start that wound healing process again. We can prevent any further delay to that wound healing, and we can also prevent that wound from becoming chronic. So the objectives of the session this evening are to understand the impact that delayed wound healing has, to understand what the barriers to healing are and discuss the management of them. And then we'll look at the benefits of standardisation and pathways as well to patient care. And we'll bring all this theory together and we'll look at how we apply this to practice with the use of some patient case studies. But just before we get started, I'd like you to just take a moment to pause. And I want you to visualise a patient that you're currently caring for, a patient that's got a wound and a wound that's presenting you with some challenges at the moment. And as we go through the presentation this evening, I want you to keep reflecting back to that patient and their wound. And I want you to think about what barriers can you identify as being there? And then what can you do to help manage those barriers? So to set the scene and to give you some context as to why it's important to be able to understand and recognise and manage those barriers to healing, I've taken some extracts of data from the Julian Guest et al. Papers. So we've got the publication from the year 2015 on the burden of chronic wounds, and we've also got data from the 2020 publication that came out just last December. And in the 2015 publication, the data showed us that we had approximately about 2.2 million people that were living with a wound. And in 2020, that data told us that it had increased to 3.8 million. What had also increased was the cost associated with being able to treat and care for those patients. So that's risen from 5.6 billion to around £8 billion a year. And what this data is showing us is that what it really highlights is the significant impact that delayed wound healing has on our health economy. And what you can also clearly see from the two data sets is that this isn't going away, and it isn't currently an ongoing issue. But it's not really just about those financial costs. It's, yes, they are an increase in pressure in chronic wound management. And yes, they do play a driver in our need to get things right first time for our patients. But there's an even greater cost than monetary value, and that's the cost on the impact of our patients and how it affects our patients' quality of life. And it's this really that generates that even bigger want and need from us as healthcare professionals to look on how we can improve wound care outcomes and improve our patients' experience. Because living with a wound over a prolonged period of time does have some considerable and detrimental effects to our patients, both physically and emotionally. And if we have a wound on the caseload that we can see is going to be hard to heal, and the barriers to that healing aren't managed well, and then that wound fails to heal in that desired time period that we want it to, it can then become chronic. And chronic wounds can take years to heal. And I'm sad to say that even sometimes wounds can remain unhealed for decades. And during this time period, this prolonged period where patients have these non-healing wounds, these chronic wounds, they're experiencing pain, significant emotional and physical distress, their mobility is often affected, and then in some cases, some patients do become socially isolated from having to live with this non-healing wound. And it doesn't only affect just our patients directly, but these wounds can also cause emotional and physical trauma to that patient's family, their carers and their loved ones as well. And again, I'm sad to say that there are times where these complex non-healing wounds can result in life-limiting or life-changing disabilities for some of our patients. And this can mean that a patient has to go possibly an amputation as a result of that unhealed wound. But with the use of a systemised and thorough holistic assessment, what we can do is identify any factors that can affect that patient's ability to be able to heal their wound. And by doing this at an early stage, it allows us to identify those potentially hard to heal wounds at this early stage, be proactive in the management of these barriers to prevent that wound from failing to heal, prevent that wound from being chronic, restore our patient's quality of life, and that will prevent any unnecessary loss of life or limb. So as I mentioned, there are many factors that contribute to the delaying of a wound healing, and it's our job as healthcare professionals to find out what they are. And we can group those factors into two categories. So we have localized factors, so that's the things that are relating to the wound itself, and we have systemic factors. So these are the factors that are related to the patient and potentially are also under the control of the patient as well. So with support, if it's something like a lifestyle need, we can assist our patient to make some changes which will then have a positive impact on their healing ability. And although these factors are separated out here, what we are likely to see in practice is that some of them will overlap and they'll be part of a domino effect. So, for example, if we have a patient that has either chosen to or been unable to choose the healthy desired lifestyle choices, such as not having a good balanced diet, so they're making poor diet choices and they're choosing to smoke. These two things can lead to processes such as diabetes and peripheral vascular disease or peripheral arterial disease. These two disease processes can then lead to ischemia, where we get poor blood flow, And they can also lead to neuropathy, where we get a loss of sensation. And due to this neuropathy, a patient might then sustain a trauma wound. And then because of the patient's poor nutritional status, uncontrolled diabetes with fluctuating blood sugar levels, reduced blood supply because of the peripheral arterial disease, this then leads to that poor healing in that wound. So if we have poor healing at the point of the wound, what we'll start to see then is the presence of devitalized tissue. That devitalized tissue can then lead on to increased risk of infection, increased presence of exudate, and then the potential for biofilm as well. So what we need to be able to do in cases like this is identify, assess, and manage those 3 key local barriers that you can see highlighted. And we need to do this in conjunction with a holistic management plan for the patient, thinking about all those systemic factors and those comorbidities as well. And then what we'll be able to do is progress that wound back towards healing again. And I just want to make note at the minute, for you to make note at the minute, that the main content of this presentation is going to be very much focused on the assessment and management of those 3 key barriers. But what it doesn't do is take away from the importance of that holistic assessment of both the patient and the wound, and we do still need to manage those patient-related factors as well. So looking at the 3 local barriers to healing that we're going to concentrate on, these are exudate, infection, and biofilm. So excess exudate and infection have for a long time been recognised as key barriers to wound healing. We know that exudate plays an important role in the ability for a wound to heal. But what we also know is exudate, where it's in excess, can become quite problematic. It can become problematic for the wound healing and problematic for our patient and their quality of life. Then we have the complications that are associated with wound infection. These can be really serious sometimes, and they can have debilitating outcomes for patients, or at worst, it can even pose a threat to that patient's life. And now we have an even greater understanding about the role that biofilm plays in delayed wound healing as well. And it's biofilm that's becoming considered to be really the leading cause of why we're seeing delayed wound healing and wound chronicity. So we're going to look at these 3 barriers individually, and we'll first look at exudate. So when we have a wound that is healing, what we see is exudate production reduce over time. So you can see here on this exudate curve how the exudate initially increases as that wound begins to debride itself, get rid of any devitalized tissue that's present on that wound bed. But then as that process has happened and we move along to where we get the production of granulation tissue forming and then finally epithelialization taking place, we can see that that exudate has begun to reduce. But where we have a wound that's not healing as expected, that exudate production can continue, and as it continues, it can become excessive. And this is due to that prolonged and ongoing inflammatory process of delayed wound healing. But what we do also know is that moisture is needed in the healing process, and that moist wounds heal 2 to 3 times faster than wounds that are kept dry. So this concept of moist wound healing is something that we've known about for a long time, and it's a very much part of a fundamental part of wound care and wound healing. And lots of the dressings that we have available to us are focused on helping us manage this moisture balance, maintaining that moist wound healing environment. So essentially, a lot of what we're doing day to day with wound management is about keeping that moisture balance. So if we have a wound that's too wet, we need to absorb and retain that exudate in that dressing. If we have a wound that's too dry, we need to think about donating some moisture to that wound. So we're always just trying to look to get this moisture balance into equilibrium. It's important for us to be able to understand as to why we need just that right amount of wound exudate. And firstly, we need to know that wound exudate isn't what we would call a passive substance. And it is made up of lots of different components that have very specific and complex properties. So depending on how much exudate there is, changes the activity of those components. So it means that it can either accelerate healing in a positive way, or it can prevent healing from taking place. So if we look at how exudate assists healing when it's in the right amount at the right time, it maintains that moist healing environment for us. It prevents the wound bed from drying out. It aids the migration of those tissue repairing cells that are needed, provides the essential nutrients for those cells to metabolize. And as we've already mentioned, it assists in that separation of that dead, devitalized tissue, that necrosis and slough that we don't want on that wound bed. But where we've got exudate in excess, what it can cause is maceration to the wound edge and that peri-wound skin area. It can delay or prevent wound healing if we don't have the right amount of those components. It can cause subsequent breakdown and further deterioration of the wound bed. And then it can also cause an increased demand on our healthcare resources, both our time as healthcare professionals, but also the increased amount of resources that we need to use, such as dressings, to be able to manage that exudate well. So the example you can see here is of a leg ulcer that's had recurrent infection. A result of that recurrent infection is excess exudate and fluid coming from that wound. We can see that exudate has now macerated that peri-wound skin area. And because that tissue is no longer healthy, this results in a delay to that wound being able to heal. So we'll move on to looking at a wound infection. So wound infection, by definition, is the invasion of a wound by proliferating microbes to a level that invokes a local or systemic response in the host. But what does that really mean to us? Well, those proliferating microbes are multiplying and growing bacteria in a wound. And when they do this, it results in us seeing a response in either the wound or the patient, depending on the extent of that infection. And where we use the word host, this is referring to the patient themselves. So to help us understand this more and what it would look like in practice and how we need to act in response, we have the wound infection continuum. So what we can see displayed here by this diagram is the level of infection increasing, and it increasing with the number of microbes and the activity of those microbes and their ability to be able to take over and infect either that wound or the patient. And by understanding this activity of bacteria, by using this infection continuum, what we can do is recognise the signs and symptoms and the level of infection that's taking place. And then we can adjust our management and interventions appropriately so that we can take back control, manage that bacterial burden, and hopefully the outcome would be that we would resolve the infection, again, allowing that wound to start healing again. Now, I'm not going to spend too much on this slide talking about the infection continuum, as later in the presentation, Julie's got a great example as to how this tool, tools like this can be incorporated into really user-friendly and patient-facing pathways and algorithms. But a really quick example is if we have a wound that's contaminated, low numbers of microbes, not very active, they don't survive in the wound, what we would describe as being transient. We don't see any change in the wound, we don't see any change in the patient. We can continue to be vigilant, we can use our non-medicated dressings, we can continue to frequently reassess that wound, use our aseptic no-touch techniques and prevent any wound infection. But if those microbes, those bacteria find themselves in a wound environment where it supports their growth, what will happen is they will multiply, increase in number, increase in their strength and activity, and they'll start to take over that wound or the patient. Then we'll start to see some changes. We'll start to see some signs and symptoms of infection. So it might be some really overt clinical signs and symptoms, that increased reddening and erythema around a wound. We might see a change in temperature. There'll be some warmth surrounding that wound as well. We might start to see some swelling and edema. There might be less obvious signs, those more covert, subtle signs, like the wound increasing in size, will identify that the wound isn't healing in a timely manner. We might have the presence of unhealthy granulation tissue. So we're going to have to adjust our management plan here. We're going to have to start looking at the use of an antimicrobial dressing to help manage that bacterial burden, those microbes on that wound bed. And depending on whether we've got local infection or systemic infection, we might also need to use antibiotic therapy as well. So if we look at why wounds don't heal when infection is present, the wound again is kept in this prolonged inflammatory phase, and then we also see a result of this, that excessive exudate again. We get decreased tissue perfusion, and this happens because the oxygen and nutrition that is available to those good cells that we want to proliferate and grow new tissue with, all that is being taken up by these bacterial cells. And then this leads to the lack of ability to be able to produce any new granulation tissue or epithelialization to take place. And then there's the toxins and enzymes. So these damage the tissue on the wound bed. This then leads to cell death, to the presence of devitalized tissue. So we get necrosis and slough that's present on that wound bed. Sometimes we might see pus as well. And then, depends on the level of infection that's there. If we have a patient that then becomes systemically unwell, so they become septic secondary to this wound, any energy that would normally be used to help the body fight against this infection and heal the wound is diverted to maintaining that patient's psychological status, because that will take precedent. So finally, I'm just going to look at biofilm with you. Now, biofilm might be a new thing to some of you, but actually it's been around for billions of years, and it's the oldest living life form on Earth. But biofilm in wounds is a phenomenon that we are still researching. We're still learning and understanding about it. But what we do already know, though, through some large research studies that have been done, is that biofilm is being seen as one of, if not the leading cause in delayed wound healing. That then leads to wound chronicity. So we're seeing in about 80% of chronic wounds that are looked at do show that they have biofilm present in them. But what is biofilm? And here we've got a definition of what biofilm is in relation to wound care. So it's microbial cells adherent to a living or non-living surface or each other that are embedded within a matrix of extracellular polymeric substance, or EPS, which may tolerate antimicrobial agents. Again, what does that mean to us? When we talk about those microbial cells that are adherent, these are bacteria that have attached themselves to a living thing, which is the wound itself or the patient's skin. A non-living thing could be any sutures that are near that wound, any prosthesis or the dressing that we've used. And then this EPS, this extracellular polymeric substance, well, this is what these bacteria have very cleverly produced to protect themselves. So these bacteria come together, they talk to each other, and they protect themselves with this slimy substance, so this EPS, and it's made up of things like sugars, proteins, the bacteria, DNA. And it's this protective layer, this slime, that then makes these bacteria very tolerant to anything we can do to try and destroy them. So our antimicrobial dressings or our antibiotics that we might want to use. So in a real sort of basic level definition of a biofilm, it can be described as bacteria that have covered themselves or embedded themselves in a thick slimy barrier of a substance that's made up of sugars and proteins. So why is biofilm a problem to us? So as I've mentioned, research is still happening, and over, say, the last 10 years or so, that evidence has been growing to say that at least 80% of chronic wounds contain a biofilm, and we've got more evidence building around this. They present a huge clinical challenge because they are tolerant to the tools that we have, those antimicrobial therapies, but they're also tolerant to our natural defenses as well, our natural response. They're really tenacious and difficult to remove, once we have been able to disrupt it and remove it, what they're capable of is reforming really, really quickly. And this can happen just in a space of 24 hours. And then there's the issue of the visibility of the presence of biofilm. So they're known as the invisible enemy for a reason. And there's loads of debate around as to whether or not we can actually see a biofilm to be able to tackle it. Again, we're seeing wounds that are kept in this low-grade inflammatory state. It's a barrier to healing all on its own. We don't get granulation tissue, we don't get reepithelialization taking place. But with a combination of different processes in wound bed preparation, such as vigorous cleansing and debriding of the wound bed and the wound edges, following that current best practice that we see about biofilm-based wound bed preparation, then we can disrupt and remove biofilm. And then once we've done that, with the use of our topical antimicrobials and dressings that have also got anti-biofilm properties in them, we can look to prevent those biofilms from reforming. So the tool that we have available to us to help us tackle and manage all these three barriers is our dressings. And selecting a dressing needs to be based on meeting that need that we've identified, that objective that we're going to set. And this could be that it's the management of that excess exudate. And what we're going to need to do is absorb and retain that exudate and protect that peri-wound skin area and that wound edge. If we need to look at managing the bacterial burden, so we've got infection present in that wound, we're going to need a dressing that's going to have intimacy on that wound bed to be able to help offload any of that microbial burden. Or if we have biofilm, we're going to need a dressing that's going to help us disrupt that biofilm, break it down, and most importantly, prevent that biofilm from reforming again. So just to summarise my section of the presentation, to be able to get things right first time for our patients, we need to, at an early point, identify those hard to heal wounds, to be able to prevent delayed wound healing, prevent wound chronicity. We then need to optimise any systemic, patient or disease related barriers to healing. And we also need to effectively manage those three key local barriers to healing that we've just walked through. And I'm going to hand over now to Julie, and Julie's going to present to us some real life case studies of how we can see this in practice and how we can do this in practice. So it's over to you, Julie.
Thanks, Jo. That was a very informative presentation, and it really highlighted the theoretical aspects of those barriers to wound healing. And the presentation that I'm going to share with you today aims to bring to life that theory by translating it into clinical practice. And I'm hoping to do this through sharing 3 case studies with you, which I believe will enhance learning in a meaningful and a positive and useful way. Before sharing the clinical case studies, I'd like to just spend a short time talking through a tool that we use in clinical practice to aid the early identification and treatment of infected wounds. And as we know, infected wounds are a barrier to wound healing. As a trust, we have implemented many different pathways to aid decision making when caring for our patients. And we found that pathways are a way of setting out a process for best practice to be followed in the treatment of a patient with a particular condition. And in practice, there's often a myriad of best practice statements, national guidelines that impact on patient care. And a pathway is a way of refining best available expert opinion on those different nursing strategies, on those care processes, and making it into a user-friendly guide that aids decision-making when you're at the patient's bedside. So this pathway, our infection identification and treatment ladder, this pathway was adapted with permission from Ruth Roper's Scottish infection ladder. And this ladder adds clinical context to that infection continuum that Jo was speaking to you about before, and it aims to guide clinical practice based on that early identification of infection. It supports antimicrobial stewardship by selecting the right dressing at the right time and for the right duration. And it also advocates the sepsis 6 red flag triggers, promoting that early recognition and prompt escalation for those patients that require it. And this tool was really designed to be used alongside your wound assessment charts. We have tissue type guides, your dressing formularies, and I'm really putting it into the context of a holistic assessment with the aim to improve patient outcomes. So now I'd like to share with you the 3 case studies from clinical practice, really to consolidate those key messages delivered in Jo's presentation and to contextualise the use of the infection identification and treatment ladder in practice. I do have to say, due to trust, information and government processes, that I've not been able to provide the actual photographs relating to the patient case studies. However, the images that we have provided are absolutely a true representation of the patient's wound. So case study 1, the barrier to healing there is excessive exudate. And this is a 60-year-old male with type 2 diabetes and hypertension. So we know already that this patient has comorbidities. This obviously is a barrier in itself to wound healing in some cases. The wound duration is 3 months, and the wound was caused by a trauma injury to the patient's leg when he was gardening. This isn't an uncommon type of injury for patients that often attend our leg ulcer clinic. The wound measures 5 centimetres in length by 6 centimetres in width, and as you can see, it's 100% sloughy. The exudate levels are wet, so there is quite a fair amount of exudate there, and we've noted that there's some malodour as well. And what we did was we performed a holistic assessment, and it was a holistic leg ulcer assessment, and that included an assessment with a handheld Doppler. And what we were able to confirm was the etiology of the wound, which was a venous leg ulcer. Now, this patient had been self-treating for 1 month before attending the treatment room. And furthermore, when the patient arrived at treatment room, there was a further delay from treatment room in referring to the leg ulcer clinic. And this then put the patient's wound in a chronic state, and particularly with that duration of 3 months. This gentleman was diagnosed as having a venous leg ulcer, and we'll know that the gold standard practice for the management of venous leg ulcers is compression, and obviously that was delayed, and that was an additional contributing factor to the overall delay in wound healing. The infection ladder identified local signs of infection, and it advocated the use of Aquacel AG plus extra. And this dressing was selected to manage that excess exudate. It absorbs vertically over the wound, and it holds the exudate in the dressing. So therefore it aids the healing by, like Jo mentioned before, being able to create that equilibrium with the right amount of moisture at the wound bed to facilitate healing, but preventing and protecting that peri-wound skin. We also used a super absorbent pad to also manage the exudate, and we were able to put this patient into full compression. So the outcome was a reduction in exudate, the signs of local infection resolved, and there was a 50% reduction in wound size within 6 weeks. And I think it's just important to point out as well that, there were some significant psychological factors to this patient and his delay in wound healing. He had to endure pain and discomfort. He actually had financial loss because he had to pay for taxis to get to treatment room and to leg ulcer clinic. And obviously this went on for some time. And also it impacted on his social activities. Having the malodor, he didn't want to go out and you know, do the things that he would have done usually. So case study 2 is looking at the infection as a barrier to healing. Now, this is an 83-year-old lady. She has rheumatoid arthritis and she's bedbound. And at the time that we saw her, she was declining to be repositioned. The wound had been there for a month by the time we got to see her, and it was caused by direct pressure. The wound measured 8 centimetres in length, 9 centimetres in width, and had a depth of 4 centimetres. As you can see from the image, it was 20% sloughy, 80% granulating, and the exudate levels were saturated. They were really high, and they were purulent, and there was localised erythema and cellulitis. And as you can see from that description, this is obviously a really significant sized wound. We conducted a holistic assessment and we were able to confirm and validate that this was actually a category 3 pressure ulcer. And we all know that pressure ulcers, you know, of a deeper nature, category 3s and 4s, are going to take longer to heal and will have many barriers to healing along that way. We were able to identify that the wound at that time was at stage 3 on the infection ladder. And we knew that we had to put interventions in quite quickly. We knew as well from the risk assessment and the holistic assessment that the patient was at high risk of developing a pressure ulcer because they were scoring amber initially on the purpose T prior to the development of the pressure ulcer, but it absolutely indicated that significant risk of this happening. What we found out through the holistic assessment as well, as I mentioned before, the patient was declining to be repositioned, but that decisions against advice wasn't thoroughly explored. There wasn't a real understanding of why the patient didn't want to be moved. And there wasn't really any considerations of other equipment to be able to reposition and offload the pressure for the patient. So we were able to obviously have that discussion with the patient. We knew that she was in a level of pain, so we addressed the pain, working with the GP, got her pain under control. And with her having the rheumatoid arthritis, she found it difficult to go right on her side. So we used a lateral turning aid that tilted her to 20 degrees actually, because she could tolerate that. So she was then able to be repositioned in a comfortable way. The infection ladder identified the spreading infection. A wound swab was taken. And unfortunately, the patient did require antibiotics. And the antibiotics were given alongside the antimicrobial dressing. We used the Aquacel AG Plus Extra, and we selected that to manage the infection because, as Jo mentioned before, it's got antimicrobial properties that are able to deal with the bacterial burden within the wound. It also manages the exudate levels, as I previously mentioned, and we were able to use a super absorbent pad alongside the Aquacel just for that absorbency. And as I mentioned, we were able to, which was a real key factor as well, get that appropriate pressure relieving equipment and that repositioning schedule in place. After doing all of those, we were able to reduce the exudate, the signs of the local cellulitis resolved, And within 3 months, we did have a significant reduction in wound size and depth. It wasn't healed within 3 months, but the wound had really progressed on. And it was a real shame with this lady because she had such a significant size wounds, and you know, those psychological factors for the patient, again, with pain. And that was pain from the wound and pain from her unmanaged rheumatoid arthritis. Obviously, with a wound that size and that deep, she was at risk of sepsis. And luckily, we managed to intervene at stage 3, because if we'd have got to stage 4, we would have been in those early signs potentially of sepsis. And, you know, there was also that risk of osteomyelitis, you know, that bony infection, which would have further exacerbated the delay in wound healing and possibly resulted in a hospital admission. And being able to intervene when we did, using the tools and the dressings that we had, we were able to prevent that from happening. So case study 3 looks at biofilms as a barrier to healing. And this is a 75-year-old lady. She has dementia, she has type 2 diabetes, and she's had transient ischemic attacks in the past. So again, significant comorbidities that will potentially delay wound healing on, you know, on their own, really. She had a duration of 6 months for this wound, which was, you know, an awful long time for this lady. She had the wound infection, which then caused dehiscence, and this was all following abdominal surgery. So really, you know, it was a surgical site infection. And now the wound was really significant in size. It was 10 centimeters in length. It was 4 centimeters in width and had a central depth of 3.5 centimeters. What we did note as well, that she had areas of undermining, so that tunneling that goes under the intact skin, where, you know, we know that there's no structures under that intact skin, but there are major tunneling and further depth that you can't see to the eye. There was 60% slough and there was 40% granulation. And the exudate levels were wet and again with malodor. So when this lady was referred to us, we made that holistic assessment. We confirmed that it had been a surgical site infection. Obviously, we were 6 months down the line here. And so now this was a chronic wound that we were dealing with. We used the infection identification ladder, and we acknowledged that she was at stage 2 and she had no wound progression. So the thing with this case study is that there was really a failure to prevent this lady's wound from reaching this chronic stage. You know, a duration of 6 months, you know, there was a lot of things that could have happened in that time before she was referred to us. And this absolutely significantly affected the wound healing. And at this stage, and before this stage, but certainly at this stage when we saw her, biofilms absolutely must be considered. And we've got a chronic wound, and really we need to consider them as a barrier to healing. So using an evidence-based approach, we managed them in an appropriate way. And what we did was we physically removed, so we took a debridement aid, and we actually manually debrided the tissue debris and the bacteria. And alongside that, once we've done the debridement, we really cleansed it well with the surfactant, with that antimicrobial cleansing fluid. And then following that, we put an antimicrobial dressing on to reduce the bacterial burden. So obviously this was Aquacel AG plus extra that we used, and that was indicated on the infection ladder. And this was selected as it has an anti-biofilm property. It's capable of breaking down the biofilms, And it's also able and effective to control that bacterial burden and bacterial growth. And it also prevents the biofilms from reforming, because that is the cycle that the biofilm's taken. And it is about taking this evidence-based approach to managing biofilms in general. And you know, this was quite a sad case when we actually went to see the lady in the initial stages of seeing her, because she had significant disruption to her home life. And that was primarily because she had lots of carers that were coming in to help her with her daily activities, and they were visiting 4 times a day. The district nurses were going in on a daily basis. So you were talking of 5 visits a day of people who were strangers to this lady, and it was highly distressing for her. And obviously this was exacerbated by her dementia. But by putting that right treatment in, and that cleansing with the surfactant, that biofilm disruption, and the use of the Aquacel AG and a foam dressing to absorb, we were able to reduce the exudate. We were able to get it to 100% granulation at the wound bed. The undermining had fully resolved, and we got a massive reduction in wound size with no depth to the wound. And this happened over, again, a 3-month period. So again, it hadn't healed, but we've got a wound now that's in more of a superficial state. So this meant that district nurses now were not going in every day. And this was such a positive outcome for this lady. And it really helped her to regain some normality and privacy in her life, and it really did significantly improve her overall quality of life. So I hope that this presentation and the 3 case studies that I've shared with you have allowed you to link that theory to practice and supported that learning in a meaningful way, and maybe allowed you to reflect on patients that you've seen in your clinical practice, and either reflecting on how you've done something at the right time and got a great outcome, or maybe how you may assess things differently and use different tools within practice to help you to make those right decisions. And to summarise, the key take-home messages that I certainly believe gained from the presentation are that holistic assessment is essential in the prevention of wound chronicity and delayed wound healing. An evidence-based standardised approach is essential in promoting the correct wound product at the right time for the right duration, and it is really dependent on that early identification of the signs of infection. And that pathways that guide clinical practice can really support that antimicrobial stewardship, also really important in practice. So I hope you've enjoyed today's presentation, and I'd like to hand you over for Alec for the question and answer session.
Thank you very much. Julie, Joanne, we've had loads of questions, loads of comments. I've been reading them as the presentation goes on. Can I just say at this point, because it's just something that I was just thinking about, that the 2 of you, genuinely, I think that was one of the best presentations I've ever listened to. And it's making me realise that probably for all these people who are watching at home, that you've made it look really, really simple. And so I just want to let everybody who's still with us know that this is actually fairly difficult, because both Julie and Joanne are essentially just presenting to a computer screen. So it's not the easiest thing to do in the world. So thank you very much, and good job. Over to the Q&A. So we've got loads of questions. So we're going to just crack straight on. The first one, Joe, is for you, and this is: How do you know if a wound has a biofilm?
Oh, that's a really good question, that, Alec. Yeah, that comes back to that invisible enemy, doesn't it? So there's lots of different ways that we can think about identifying a wound with a biofilm. So again, split them into categories. We've got indirect sort of indicators and visual indicators. So if we think about some of those indirect ones, that's recognizing a wound that isn't progressing towards healing, recognizing a patient that's had multiple use of antibiotics, multiple use of antimicrobial treatments that haven't worked, because that biofilm's there, it's fighting against it, we're not able to penetrate through. And then in terms of the visual identified indicators, you can, or the suggestion, some of us believe, I'm one of them, that in the very mature state of biofilm, it doesn't stay microscopic and it becomes macroscopic. So if it's macroscopic, it means we can see it with our eyes. And some of those things can be that slimy substance that we talk about, that EPS. It can be a slough-like substance on the wound, so it's really pale yellow, pale green substance on the wound bed, but we can easily wipe it away. The key thing with that is it just as quickly comes back, so that 24-hour time period. So if we're seeing that happen on the wound bed, we can pretty much say we've got a biofilm. But the only thing I want to add to that very quickly is if we think about that data that we're getting now, that research that we're getting that's telling us these non-healing wounds, these chronic wounds specifically that have been there for a long time, 80% of them are showing up as having biofilm. And the majority of our caseloads that we've got are patients with long-term delayed non-healing chronic wounds. So do we need to be able to see it, or should we just start making some assumptions that these wounds have got biofilm, so let's just tackle them and we'll hopefully start to see healing in these wounds?
And I guess the flip side of that is that there's no harm in making the assumption there's a biofilm there. You're not going to do any damage to the wound by making the assumption right off that there is biofilm. So that's a very good way of looking at it. Thank you, Jo. Julie, the next question is for you. How do I know if my dressing is managing the exudate effectively?
Well, I think, Alex, it's really about knowing the properties of your dressing first. So knowing what dressings are designed to hold exudate, what is their fluid handling capability. And as we mentioned before in the presentation, it's about getting that equilibrium. So it's about getting that balance between the right amount of moisture at the wound bed, but really protecting that peri-wound area. And a dressing that is managing your exudate effectively will prevent that peri-wound maceration, but it will still keep that moisture at the wound bed. And if it was too absorbent, then we'd find that the wound bed was drying out. So it's all about knowing your dressings, knowing their capabilities, and when you're reassessing your wound, observing for maceration and wetness at the peri-wound area, or looking to see whether it's actually quite dry and the dressing's adhering to it. So yeah, it's about that moist wound environment and that balance.
Brilliant, thank you, Julie. I'm going to stick with you, and we're going to go back to the topic of biofilms. And this is the question is, what can I do to prevent biofilm reforming?
So I briefly mentioned before about within the context of the case study that it's really not a one-step solution. So firstly, it's about taking that evidence-based approach and looking at, you know, the evidence out there to support how do we effectively remove them and prevent that reformation of them. So it will be, and as you know, it's stated in the infection ladder, it's about the physical removal. If the patient can tolerate having, you know, using a debridement pad to actually remove that debris from the wound bed, then it's about using that antimicrobial, that surfactant that we call that antimicrobial cleansing fluid to reduce that bacterial burden. And then again, putting the right dressing on. Like I mentioned in the case study, Aquacel AG Plus Extra has got the data behind it and the research behind it to show that it is effective in preventing that that biofilm reformation, and this is an ongoing process till you start seeing progression within the wound.
Okay, you mentioned about cleansing fluids. Then I happen to notice quite a few questions about specific cleansing fluids that people were asking during the presentation. So just for the audience, we tend not to answer any questions about specific products, especially if they're not provided by the company that is supporting the event, and that's got nothing to do with any. It's purely because really you need someone who's a specialist in that product, somebody who works for that company, who is a product specialist that can answer the questions. But if you do have any questions about anything specific, if we haven't got through to them yet, just a reminder that you can still send them through. And what we'll be doing at the end of the present, or what we'll be doing probably tomorrow or Monday, is we put a copy of this video onto the website, along with a copy of all of the questions that have come through. And even if yours hasn't been answered, then we'll get to that and we'll share the answer to those questions that we don't get through tonight on a PDF that you can download. And hopefully, if you've asked one tonight, you'll get yours answered either now or later via our website. So next question, Joe, this is back to you. This is, when you use an antimicrobial dressing, can you only use it for 2 weeks? I've heard about the 2-week antimicrobial rule.
Oh yeah, this is something that gets asked quite a bit actually. So when we talk about this 2-week rule with antimicrobials, we're talking about 2 weeks of reassessment. So it's just like we would with any wound when we're using either a medicated dressing such as an antimicrobial or a non-medicated dressing. What we need to do is make sure that at minimum at 2 weeks we need to reassess the effectiveness of the dressing that we're using. It doesn't necessarily mean that at 2 weeks we have to stop the use of that dressing if it is an antimicrobial, but we just need to rationalise whether we are going to continue with its use. Do we see that the efficacy in continuing the use of the antimicrobial? Might be that we stop it, we swap to a non-medicated dressing, and that's absolutely fine. And at 2 weeks assessment, we're still seeing progression. It might be that if we stop it at 2 weeks reassessment again, we see that we need to reuse that antimicrobial dressing again. So it's just always about having a time frame to remind us to return, do that full assessment, and give rationale really to the appropriate use of the dressing that we're using. I'll probably good to have a caveat in saying you'll most likely have something written in your local policies and guidelines around your use of antimicrobials, and every product can be slightly different as well. So it does depend on your selection of antimicrobials that you've got on formulary. So do just double check. Always go back to your local guidelines and policies and look at your instructions for use with your antimicrobial products that you've got on formulary as well. Don't know if you'd add anything to that, Julie.
No, I think you're quite right, Joe, in terms of, it is being aware of those local guidelines. I think, generally that 2-week rule, as you said, is put there as a point of reassessment, and a point of, is the wound progressing? Are we doing the right thing, or do we need to do something different? And I think going back as well to what Alec had mentioned before with one of the questions about surfactants, again, look at your local formulary as well. They will be very likely for one to be listed on there, and it's about looking, the evidence will be behind why that's been selected for your local formulary.
Yeah, good. There's a couple of questions here. There's one here that I think we've answered actually, which was with hard to heal wounds, do we just presume that biofilm is present? And I think, Joe, that you mentioned that that's probably a good rule of thumb to actually do that. The next question is, sorry, you can tell we're live because I'm actually reading the questions that are being sent through to me, and I've just skipped something. So it's following on from question 5, which is, do we presume that the biofilm is present? Is if biofilm is in a wound, is there infection present in that wound? So I'm going to pass that over to the two of you, and then I think that's probably the last question for this evening. So Joe, do you want to, if there's biofilm in the wound, does that mean that there's infection?
Essentially, because we've got the presence of bacteria, and we've got the presence of bacteria that are really tenacious and have created themselves this lovely little dome to live in. So you think of it as like a bit of a biome above this wound. So what you will see, and I didn't say that when we were talking about how you can observe for a biofilm, you will see some signs of infection and inflammation, some of those classic signs. You can see it because that biofilm can take form at any point along that infection continuum. So it could be that we've got local infection, signs and symptoms, but also a biofilm is there as well. So yes, in a nutshell, in a very short answer, yes, it's quite a, like I say, we're learning about biofilm. We know a lot, but we're still learning about biofilm.
Yeah, good. I think I like the sort of brushing your teeth analogy when it comes to biofilm. I think that's just a really clear way of trying to understand it, because I've heard that a number of times, and I just think it's a very easy way to understand biofilm. Julie, Joe, we're going to finish now because we've run over time slightly. So I do apologize for those of you who are looking to go and get a glass of wine or eat your dinner or whatever that is. We're going to put some slides up on the screen now, and some links will be available via our website to get access to these as well. So for further information about any of the ConvaTec products that have either been mentioned tonight or anything else that you may be interested in, then you can go to www.convatec.co.uk/wound-skin. Do visit that site, because actually you can also get samples of anything that you like. They'll have their product information on there, and you can request samples that will be sent directly to you also. Or you can email wounds.webcare@convatec.com. The certificate link should be available on your screen now. Please do download it and keep that towards your revalidation. Recording from this evening, the edited recording and the slides will be available on our website and on the Facebook page from tomorrow. Just leaves me to say, Julie and Joe, fantastic presentation. I certainly enjoyed it. I know that from the viewers' comments, they've enjoyed it too. We look forward to welcoming you all again soon. For those of you that are coming to Milton Keynes to Wound Care Today next week, which is our first big major conference since pre the big C word, we look forward to seeing you there. That's it from us. Good night, everybody. Have a good evening, and we look forward to catching up with you soon. Good night.